welcome to the Irish Cancer Society very first hybrid event. It's great to see so many of you here in person, and I believe we have over 300 registered online, so thanks so much for coming. Tonight we're going to have a talk that's very important to the Irish Cancer Society. As part of our current strategy, it's really vital that the Irish Cancer Society are developing programs that seek to improve the experiences and outcomes of all people affected by cancer. So in line with that, in 2019, we, in consultation with Professor Martha Hickey, developed the Women's Health Initiative, which is a survivorship research programme in Dublin and Cork aimed at improving the care and outcomes for women affected by cancer, including for women who have gone through menopause after cancer. So it is therefore an absolute pleasure to have Professor Martha Hickey today to talk to us on managing menopause after cancer. Martha is a Professor of Obstetrics and Gynecology at the University of Melbourne and Director of the Gynecology Research Centre at the Royal Women's Hospital. We had Martha in Ireland in 2019 where she gave a fantastic talk, and we are delighted that she's visiting Ireland again to share her expertise. So just a few logistics before we get started. Please note that this event is being recorded. This is just so we can share it after the fact for people who can't attend. For online attendees, we have Niamh and Jack online, and they'll help you with any technical issues, so please put any issues that you're having into the chat function. We have allocated lots of time for questions, so please do ask all the questions you want. We have a Q&A function online on the right-hand side of your panel, and you can place any questions that you have throughout the talk in the Q&A function. For in-person attendees, we will have a roving mic, so please just put up your hand and we'll answer any questions that you have at the end. And then just to say additionally, if you have any worries or concerns at the end of this talk, for in-person attendees, we have a nurse line over here in a stall, and for anyone online, you can of course give the nurse line a ring from the Irish Cancer Society at 1-800-200-700. And with that, I'm just going to pass over to Martha.
Thank you. Thanks, Claire, and welcome everybody in person and online. Tonight I'm going to talk about approaches to managing common symptoms in women who cancer survivors, and I realise that it won't cover everything or everybody, and it won't cover all the symptoms, and I'm interested when we get to the questions time for people to bring up things that they feel that have not been covered. So just to think about the scope of this issue, so there are about 173,000 cancer survivors in Ireland, and that's 4% of the population, and about half of those are women. And because of improvements in treatments and survival, it's expected that the number of cancer survivors will double by about 2040. And I think critical to this talk and to my clinical practice is recognising that cancer treatments affect men and women differently. So women get different cancers, they have different treatments, and they have different consequences from their treatment. And it's not only survival from cancer that matters. It does matter, of course, but it's not the only thing that matters. And I think an important focus as well for communicating these kinds of issues to the wider community is it's not just about women's cancers. Of course, breast cancer is common, gynecological cancers are common, but many women have other kinds of cancers that affect women and men. And that's the time when often the specific effects on women are overlooked. So, I'll go through these different issues. These are areas that cancer treatment may affect women. So it may affect fertility. It may cause menopausal symptoms for all sorts of reasons. It might cause difficulties with sex, with sleep, and also with mood. And for some treatments, there may be long-term consequences for cardiovascular disease and osteoporosis. And for those who are in the moment treating the cancer that they have to treat with the treatment they've been recommended, it's difficult to come to terms with all of these issues, especially when in the long term there are unknowns. So I'm going to talk first about infertility after cancer. So the reason that cancer treatment causes infertility in most cases is because the kinds of drugs, chemotherapy drugs, that are toxic to cancer are also toxic to other cells that divide rapidly. And in particular, those are the eggs that we have in our ovaries. So for reasons nobody really understands, all the eggs that you're ever going to have developed before you're born. And at about 5 weeks gestation, so for 5 weeks of pregnancy, nearly all of them die for reasons nobody understands. And then when you're born with all the eggs that you're ever going to have. And then from puberty onwards, you're losing groups of eggs each time you have a menstrual cycle. You can't protect them by taking the oral contraceptive pill or anything like that. But when those eggs run out, that then leads to menopause. And a low supply of eggs, what's sometimes called a low ovarian reserve, can lead to infertility. So the kinds of things that affect that are chemotherapy for common cancers, such as breast cancer, chemotherapy prior to a stem cell transplant for hematological cancers. Radiation the ovaries are very sensitive to radiation. So radiation in the pelvis, for example, for cervical cancer or for a low colorectal cancer, will almost always cause the ovaries to stop functioning. But it's not always so straightforward, because menstrual periods, which are a marker of fertility, though not an exact marker, periods may stop for years for younger women and then restart again. So there aren't really any reliable ways to predict who might start having periods again and who might be fertile. But there's some recent research showing that a blood test called anti-Müllerian hormone, or AMH, after chemotherapy can be a good predictor of later fertility. So if there's no AMH after the chemotherapy, probably that's it as far as the ovaries are concerned. And even if periods return, fertility is still reduced. So we're working on ways, and our group have some work in this field, of trying to protect the ovaries from the effect of chemotherapy, but at the moment it's not there. So a relatively few women do get pregnant and continue with a pregnancy after cancer. So it's hard to have very strong evidence about that because of the small numbers. That's partly because of age, and it's partly from choice. But for women who do get pregnant after cancer, that pregnancy itself may carry some risk. For example, of miscarriage, the baby being smaller than expected, and for women who've had radiation, that can damage the muscles of the uterus such that they can't expand to allow a pregnancy to grow, and can even rupture. These are rare things, but they're possible. So pregnancy after cancer is usually considered to be a high-risk pregnancy. So what can be done about infertility after cancer? This is a really big issue for younger women, particularly, well, most of the evidence is from young breast cancer patients. And some of those women, if they know that their chemotherapy might cause infertility, they will choose a different kind of treatment. So they might choose a treatment that is less likely to work just to preserve their fertility. And I think that helps me understand how people need to have all the information that they can get in order to make informed decisions. So injections of a drug called Zoladex before chemotherapy can help to protect the ovaries for some women. And where I work in Melbourne, that is standard practice now for all young women with breast cancer. I don't think it's happening here. I think it's a bit sporadic here from what I hear. There's also the issue of fertility preservation. So young women who haven't yet completed or started their families, who are about to start treatment that might make them infertile, should be offered the opportunity to discuss fertility preservation, meaning is there something that they can do that might help them to have a baby in the future. Now, there may not be anything, but it's important to have had the discussion. In some cases, tissue from the ovaries can be collected and frozen in the hope that that might help with a pregnancy later, but that technology is still very new, and there's very few pregnancies just from frozen ovarian tissue. And for women who have a blood cancer like a lymphoma or a leukemia, there's the risk that putting that tissue back might actually transfer back cancerous tissue, so it's not without risk. But in general, for women who have breast cancer before menopause, and that's about 25% of breast cancer patients, about a quarter of breast cancer patients, the chemotherapy that they have will add about 10 years on the age of their ovaries. So if you're 42 and you have breast cancer and you have chemotherapy, your ovaries will be about the age of somebody who's 52, and that's after menopause. But of course it varies depending on how old you are when it starts. So this is a decision aid that was developed by my colleague Michelle Peach, who's going to be here tomorrow, I think. She developed this a few years ago now, but it's a fantastic resource. It's freely available through Breast Cancer Network Australia, and it helps women making decisions about fertility prior to their chemotherapy weigh up pros and cons. So it gives information, that's one thing. But the other thing it does is allow you to put your personal concerns and values into the mix to help you come up with a decision. So that's something I think we've circulated here, but anybody can download. And the research that we've done with this decision aid show that the women who've had this are more likely to say that they made an informed choice, they are certain about the decisions that they make, and they have less regret, which down the line, which is also an important measure, I think. So I'm going to go on to talk about menopause after cancer. So menopause, of course, is normal at around age 50, and it's called premature if it's under 40 and early if it's under 45. So anything from 45 upwards is considered to be normal. And chemotherapy and radiation, the same things that can cause infertility, are the things that cause menopause. And I've just listed some of the common cancers there that treatments commonly cause menopause. And of course, if you have to have both ovaries removed, which might be the case for ovarian cancer, then you will go immediately into surgical menopause because of that. And the other reasons why women commonly get menopausal symptoms after cancer is from breast cancer taking endocrine therapy such as tamoxifen or a aromatase inhibitor, and they commonly cause hot flushes and night sweats, which are menopause symptoms. So there's lots of different reasons why these symptoms might occur. Makes them very frequent. So I think after cancer particularly, it's very hard to know what symptoms are due to menopause and what are due to other things that happen after cancer treatment, such as fatigue. It's hard to unpick those things. But as far as menopause is concerned, hot flushes and night sweats are the main symptom. Vaginal dryness is also really common, and mood and sleep disturbance. And of course, fatigue is a common thing after cancer, and it could be the sleep disturbance that's making you tired. It's hard, as I said, it's very hard to unpick. So there are treatments available for menopausal symptoms after cancer, and of those treatments, HRT is probably the most effective. Now, it's not recommended for everybody, and particularly after breast cancer, it's not recommended. But after some other cancers, it appears that it's safe to take HRT. So, for example, the gynecological cancers, ovarian cancer, cervix cancer, after colorectal cancer, and after blood cancers like leukemia and lymphoma. So, on an individualized basis, HRT is generally safe to take in those circumstances. And the benefits of HRT, and it treats the symptoms of hot flushes and night sweats, vaginal dryness, and it also improves bone strength and prevents fracture. So there's a number of different things that it does. But vaginal dryness, which, as I mentioned before, is really common in postmenopausal women generally, and after cancer specifically, can be treated with just local or topical estrogen, meaning a cream that can be put in the vagina. And most women can safely use that. It does need a discussion with the oncologist after breast cancer, but in most cases that's safe to use. So in addition to the hormonal treatments for women who want to avoid hormones or who can't take hormones, there are an increasing number of non-hormonal treatments. And I think I find it easy to split these into two things, which are drug-free treatments, and that would be cognitive behavior therapy and hypnosis and acupuncture in some women, and drug treatments, which are mostly the antidepressants, but also gabapentin, which is good for sleep disturbance. And this picture, by the way, is an image from Flesh After 50, which was an art project which I ran last year. And one of the art pieces was 500 images of naked women over 50. So this is one of them. That's what she chose to wear. I'm not sure what it is, actually. It could be a chicken. Anyway. So in with all the new data about what works for hot flushes, we've got also now better evidence about what doesn't work. And I've listed some of those things here, and I've put acupuncture, you can see, is in there twice because the evidence is a bit conflicting. But I'm not saying don't do these things because they might be good for your general health and well-being, but they don't treat hot flushes. And I think it's important that we know what works and what doesn't work. And bioidentical compounds, it's a big thing where I am. Do you have them here? It's things like the chemist makes them up. They take samples from you of your hair or saliva and make up something. No, good. So they often contain very high doses of hormones, including estrogen, and their safety, they haven't been shown to be safe. And I know there are lots of over-the-counter products for menopause, but none of those have been shown to be effective. And it's important because you can spend a lot of money on those types of things for something that doesn't work. So another area I've been involved with is support for women who are at high risk of breast and ovarian cancer because they carry the BRCA1 or BRCA2 pathogenic variant. So it's about 1 in 400 women. And this woman, who was also part of Flesh After 50, has written fake underneath those breasts, and then she's written above it, the real ones tried to kill me. So she was a woman who carries a BRCA gene who was making a very strong statement about the effects of that. So for these women, we've produced these resources which which provide information about having surgical menopause. So for BRCA1 and BRCA2 women, they'll be recommended to have their ovaries removed surgically to prevent ovarian cancer, which it's very effective at doing, but it does then cause immediate surgical menopause. And our research showed us that women weren't prepared for surgical menopause and didn't know what to expect. And some of them were avoiding the surgery because of their concerns. So we produced these resources to try, and again, these are freely available. Specifically for women who've had breast cancer, with Cancer Australia, we produced this booklet a few years ago now, 2016, which is about managing menopausal symptoms. And I'm pleased to say that since this came out, there are new things available. So we're getting, the number of effective treatments is increasing. So I'm going to talk about sexual difficulties after cancer. So most people who've had cancer have sexual difficulties, men and women. For women, there's I've just listed some reasons there, but many women will experience more than one of those things, or there might be additional reasons why sex becomes difficult after cancer. And almost everyone finds it difficult to talk about sex. I mentioned vaginal estrogens before. They are not a treatment necessarily for sexual difficulties after cancer, but they do help with vaginal dryness. So you can their prescription, I think their prescription here also, available as creams or pessaries. They'll reduce dryness and discomfort. They also help with some urinary symptoms like urgency and preventing repeated urinary tract infections. And they can be used in the long term. So no real harm demonstrated from vaginal estrogens. In terms of non-hormonal treatments for vaginal dryness, there's not really any. It's really been a real problem finding effective treatments. Lubricants might work. We did a randomized trial of silicone versus water-based lubricants, and we found that the silicone-based lubricants were better, but more than 80% of women still had pain. So I wasn't convinced that lubricants really made a huge difference. Local anesthetic to the vulva might help, and intravaginal testosterone, we don't know enough about that yet, particularly not after cancer. So it's a bit of a gap here. So women might also experience changes in their desire and response after cancer. In terms of what can be done, prevention, for women who are having radiation treatment, using a vaginal cylinder after their treatment might be helpful, plus physiotherapy is really important. Talking with a partner healthcare team, and there's some study published there showing that in Ireland most cancer specialists do not discuss sexual issues with their patients. It's probably the same everywhere, but that's Irish data. So if you feel that you want to discuss those things and have some advice, you need to ask for a referral to discuss sexual problems and get more information. Testosterone, I think there is a female testosterone product now available in Ireland. In the non-cancer population, it does seem to help with sexual responsiveness. So one additional sexually satisfying event a month is what the papers show, but we don't know anything really about their safety after cancer. But to be fair, we probably never will, so it is an uncertainty. So I'm now going to talk about sleep and sleep disturbance after cancer, and this image is of another piece from Flesh After 50, which was some wax models that a young woman made of her mother and her aunts and her older relatives, just relaxing and lying around, and she made these beautiful images. So most people who've had cancer have sleep disturbance. So 30 to 60% versus 12% in the general population. And the risk of those things is almost doubled in women. And one of the reasons sleep disturbance is so important, not just because it's disruptive in the day, but it makes it harder to cope with all the other symptoms that you might be having to deal with. And it adds to the burden of cancer, in particular with fatigue, has a direct relationship with depression and mood disturbance. And it might lead to an increased use of pain medication and sleep medication. So sleep underpins so many other functions that we need to do in the day. And I've just put this up from the Sleep Foundation, looking at the vicious cycle of insomnia, that when your sleep is disturbed, you feel tired and frustrated because your sleep's been poor. That then makes it harder for you to get to sleep, and then you get more tired, and then you nap during the day, and now you're not sleepy at bedtime, then you can't get to sleep at night, and so it goes around. We all recognise that cycle, I think. So the first line treatments for sleep disturbance for everybody are psychological therapies. So they've been well proven. In fact, NICE Guidelines in the UK has just recommended Sleepio, which is an online sleep program for sleep disturbance as first line in the general population. So it's a big change, and that really reflects how well the studies have shown that these kinds of sleep programs work. And I know that Donald Brennan and the group here are planning to do a study of Sleepio in women after cancer to hopefully demonstrate that it's as effective in the cancer population as it is with everybody else. In terms of drug treatments for sleep, so melatonin, it does reduce your time to fall asleep by about 20 minutes. Doesn't work for other parts. Remeltion, I'm not sure you have, but it's very expensive and it doesn't do anything much better. What's called the Z drugs, such as Zolpidem, for women who've had breast cancer and are having hot flushes and disturbed sleep, they improve quality of life. So whilst don't generally recommend these things in the long term, they do seem to be effective. And the benzodiazepines, like Valium, for example, short term and can be addictive, meaning that you need more and more to get the same effect. So this is a program we've worked on in Melbourne, which is also a psychological therapy with something called step care for sleep disturbance after cancer. So step care means that you start off with a relatively sort of small intervention, and then you continue to increase it until the problem is solved. And this has been effective. We've rolled this out now for men and women. We're just doing a program for adolescents and young adults. So mood disturbance after cancer. It's 1 in 6 of us will experience depression. So it's a very high rate. It's about twice that found in men. And about 1 in 3 women will experience anxiety. So, of course, by the time the cancer comes, you might already have experienced these things. They're not necessary, or they might be new as a result of the cancer or its treatment. About a 1.5 times increase with cancer. And not surprisingly, it's those who've had a previous experience of those kinds of problems who are most at risk of experiencing them again. And a particularly risky period is the end of treatment, which I think many people recognise that time when they're suddenly let loose to sort themselves out, having had a very intensive medical input. So the particular risk groups to consider, I think, for clinicians and for women to be aware of are those from ethnic minorities or who are isolated, women who feel unsafe, and that's 1 in 6 in Australia, where I come from, those who are financially insecure, and those who have an addiction to alcohol. So if one of these things coincides with a cancer treatment, then that's going to create a higher risk. So in terms of managing mood after cancer, information, of course, is the first thing. Talking with your support team, finding out about financial help if that's contributing to the problem. Exercising, looking after your body. It's been hard to do that through COVID, but hopefully now easier. Mindfulness and meditation. Mindfulness particularly has a growing reputation for being a positive intervention on all kinds of physical and mental health. And getting treatment, either psychological treatment as CBT or antidepressants. And there are a growing number of online CBT programs for depression and anxiety, which can be easier to access if there's a shortage of psychologists, which there always is. So this is how we run our program in Australia as a multidisciplinary model for women who've had cancer. So multidisciplinary care creates a common platform between clinicians. We particularly wanted to avoid conflicting advice about treatment. So, for example, one doctor saying you can take vaginal estrogen and the other doctor saying, no, that'll make cancer come back. So that was a big motivation for doing this. We wanted to make things more efficient. We didn't want patients having to turn up for multiple appointments with different clinicians to deal with similar problems. And we wanted to make sure that practice was evidence-based. And we felt we could achieve more together than we could individually. So we don't have all of these people in the clinic. We just have me or another gynecologist, and we have an endocrinologist, hopefully, and we have a GP who has an interest in sexual function, and a nurse who coordinates the service. But we work closely across these other people. So the women are referred, this is in breast cancer, maybe from a breast surgeon or the oncologist or the breast care nurse from the GP. They have a clinical review that used to be in person, but increasingly it's via telehealth, meaning video telehealth. We have guidelines on symptom management with a nurse specialist, patient information, data collection, and when we have conflicting or difficult problems, we try and resolve them across the multidisciplinary team. So as I mentioned, these are the people who were involved contributing to the team, and my understanding is that here in Dublin you'll be having similar kinds of services offered over coming years. So telehealth was something we did because we wanted to avoid our cancer patients having to go to too many appointments and take time off work and find a parking space or get somebody to look after the kids. And most of the time we didn't need to examine anybody, so it seemed reasonable for us to do it on a screen. So we offered it to everybody. This has been for about 4 years, and only about 30% of people took it up. A lot of people wanted to come in person. But then when COVID came, we've switched to doing it for everybody. And I think we'll end up continuing to offer that. Overall, patients like it. So just to summarise this before we go into questions, The long-term effects of cancer treatment in women may include, as I've mentioned, infertility, menopausal symptoms, sexual difficulties, mood and sleep disturbance. I haven't talked about long-term health issues because it does differ a lot depending on the cancer and the treatment and the individual. So it's not less, I didn't want to make generalizations about that. So most of these symptoms can be treated and some are actually preventable. If you can manage them properly, they improve quality of life for women and have benefits for relationships and ability to get back to normal function, including getting back to work. Multidisciplinary care is cost effective, it's more convenient for patients than having multiple appointments with different specialists. And having a research platform provides patients with access to treatments that wouldn't normally be available. And it allows women's priorities and voices to be heard. So, thank you. I found this card in the Hugh Lane gallery, actually. I couldn't resist it.
Thanks so much, Martha.
Thanks.
That was a brilliant talk and really excellent informative. Just before we kick off with specific questions, just to say that Martha can, of course, comment on questions very generally, but if you do have any specific questions about your own cancer care, you need to ask your own medical team because they would obviously have your medical history and everything. So just before we get started. So have we any questions from the audience? We have Zaki here with the roving mic and she'll answer any of your questions, but we might just kick off with some online questions. So Martha, there's been a few questions in about the whole role of HRT if you've had breast cancer previously, and some of the people online just want some clarity around, is HRT not recommended for breast cancer now that the WHI study has been debunked, and how that they can manage conflicting advice between some clinicians that say that they can take HRT and then some that say that they can't.
Thanks. So first of all, the WHI study hasn't been debunked. It was the largest randomised controlled trial of HRT ever performed, and it's given us most of what we know about the risks and benefits of HRT. So secondly, that study was not about breast cancer. What it showed is that combined HRT increased the risk of getting breast cancer in the first place. So breast cancer was an outcome, but as a result of taking HRT, not whether it was safe in women who'd had breast cancer. In terms of whether it's safe in women who've had breast cancer, the overall evidence is very limited because there hasn't been very many studies that have given HRT to women who've had breast cancer for obvious reasons. But those that have been conducted overall have showed an increased risk of recurrence. There may be very specific, it's an individualized thing, there may be very specific cases, for example, for a woman who's had an estrogen receptor negative cancer and an early estrogen receptor negative cancer who's had a bilateral mastectomy, who's got bad symptoms and wants to try HRT, that there's a discussion for her with her oncologist.
Thanks, Martha. We have a couple of questions in here about dealing with anxiety. I know you talked a little bit about it, but maybe you want to expand. So I suppose issues of anxiety after cancer and any advice that you might have when they don't want to take antidepressants.
Yeah. So the best treatment for anxiety is psychological treatment. So it's cognitive behavior therapy and mindfulness-based stress reduction are the best treatments. They're long-lasting. The side effects you get from those treatments are better sleep and better mood, rather than side effects that you can often get when you take medication. So I'd strongly recommend those non-drug therapies for anxiety.
Thank you. Do we have any questions from the audience? Yeah, Becca.
I just have a quick question about surgical induced menopause. Are there any guidelines in relation to how quickly you should be started on HRT if you've had your ovaries removed?
Look, we're just writing some guidelines on surgical menopause because there weren't any. It was a really important gap. Not really. I mean, from my own perspective, I think that it depends, right? So it depends on the reasons for the surgical menopause, but assuming those are not to do with any hormone-dependent cancer, and there's a plan being made with you and with your doctors about taking HRT afterwards, then I think it's reasonable to start almost immediately afterwards, providing it's been laparoscopic surgery.
Can I just ask you, it wasn't started immediately? You say it was I just heard something is that you've estrogen receptors all over your body, and if they're not fed the estrogen, they can close up or not.
It's really alarmist. I know, I've heard that stuff as well. I mean, we do have estrogen receptors in all parts of our body, and lots of receptors for lots of other things as well. But it is normal for women to experience menopause and have a reduction in their estrogen. What's different in surgical menopause is that you've got no estrogen, basically, or very little. So that ongoing production of low levels of estrogen and also some testosterone that the ovaries would do after menopause isn't there. So that's a reason for considering estrogen until around 50.
It was just, I was 8 months before I actually got onto HRT. It wasn't offered in the hospital. I was sent out with nothing. And I went about it myself, but I'm very poorly absorbing. And I'm always wondering, is it because of the delay?
Are you not using a patch?
I am now, but it was 8 months before I was started on it. And I would just wonder, is that because they started to close down or something?
I don't know. No, because they won't go away, those receptors. They'll still be there. No, that shouldn't make a difference.
Okay, thank you.
Thank you. One more question in the audience. Yeah, you might just hold the mic right up to your mouth so the people online can hear properly as well.
No problem. You didn't mention anything about a healthy diet. What are your thoughts on that and symptoms of menopause and a healthy lifestyle?
Yeah, it's a really important point. So diet and exercise are really important at any stage in life, and probably particularly after cancer. They don't, I guess, as far as anybody knows, they don't make any difference for any of the kind of things I was talking about. So
And what are your thoughts on phytoestrogens if someone's on aromatase inhibitors?
amount of phytoestrogen before it would even have any measurable effect. Yes, it's a discussion with the oncologist, I think. Are they saying avoids phytoestrogen?
Pardon?
Is it you talk about dietary?
Yes, dietary, not supplementary. Yeah, dietary.
Yeah. So I think in your diet you'd have to take an enormous amount of dietary phytoestrogen to have much impact on circulating estrogens.
Thank you. So what if you want to have a conversation with your doctor about some of these issues and feel a bit hesitant? How would you recommend broaching that subject?
You could say, I went to a talk and I heard this and this, and that might be an opener, maybe. Or I read something maybe on your website or something like that. And, because it is a very rapidly changing area, and it might, for doctors who aren't interested in the area or don't specialise in the area, it may be hard for them to keep up with the amount of change. And an example of that would be, the non-hormonal treatments for menopausal symptoms. Some of you might have been told there wasn't anything you could take if you had those symptoms, and that's not the case. But it is changing quite rapidly. So new things are coming out quite quickly.
Thank you. The advice for management of arthralgia associated with endocrine therapy.
Yeah. So arthralgia, or muscle and joint pain, is a really common symptom in women who take aromatase inhibitors. I think that there isn't much good treatment for that. My understanding is that exercise can be helpful, but I don't think there are many good treatments for it. I don't think people really understand what's causing it. So sorry, that's not very helpful, but it's not something that I treat in my clinical practice.
Have we any questions in the audience? We might just go to the audience again. Yeah. And if you can please just speak right up into the mic, please.
Hi, I know it was briefly mentioned in the talk. Would you have any comment on any of the more long-term effects of hormone suppression, such as rising cholesterol levels, heart conditions?
Are you talking about ovarian suppression like GnRH agonist?
Yes.
Zoladex?
Yeah.
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 Yeah. Look, it's a really good question also. I'm not sure that anybody's ever looked at that. I guess what's reassuring would be that, menopause itself, although as you get older, you increase your risk of things like cardiovascular disease and metabolic disease. Menopause itself isn't a risk factor for those things to happen. It's an aging thing rather than menopause. But, drugs like Zoladex weren't really designed to be used in the long term. So it's relatively recently that they've been used in the long term. And hopefully somebody's studying that because it needs to be known. Yeah. But it comes back to your comment before really about diet and exercise. I mean, that's all that you can do really is to optimize your heart health as much as possible by following those sorts of guidelines.
Thank you. And we have somebody here who had a radical hysterectomy for endometrial cancer 3 days ago, and they want to know how long can they until they expect to experience menopausal symptoms, do you think?
How old is she?
Didn't say.
Yeah, so it depends. It really
Yeah.
depends on age. So just as a general, what happens when you get symptoms after surgical menopause question, by 6 weeks. So I don't know exactly when, but by 6 weeks you could have it.
Okay, thank you. How can you manage the cognitive issues when you've had breast cancer, ER positive, when you can't take HRT?
Yeah, so cognition is a big concern for lots of people. I think that the whole area of cognition around chemotherapy and breast cancer is quite well studied, and my understanding is that although a lot of women experience cognitive changes, the actual tests that are done for the things for cognition, which is mainly memory tests, don't really show very much difference. So maybe the tests aren't quite testing the right thing, perhaps. But for that particular question, HRT is not a treatment for cognition problems.
Great. We've got somebody here who's in surgery-induced menopause, and they've tried a few different meds and different patches, but still not working. They were just wondering, is there other options out there?
So it depends on the reason for the surgically induced menopause.
Cervical cancer.
Yeah, so she would be eligible to take HRT. So she probably needs to see somebody who works in menopause who can help find the right product for her.
Thank you. Do we have any more? Yep. An audience question here.
I'm totally confused about this HRT and not being able to take it after breast cancer. I myself was ER negative, but I was HER positive. And my oncologist specifically said, you're not a candidate for HRT. So I was on a trial with that gabapentin actually and Sleepio. That just didn't agree with me at all. I was like a, crazy woman. So I just feel like I'm going around in circles. Like, how do I find how do I find information? Can I take HRT?
Yeah.
Who should I go to?
Nobody really knows is the short answer. But there's a study being published relatively recently, last year I think, that looked very specifically at that question. What's the effect of taking HRT after breast cancer? And then secondly, does that differ depending on whether it's an estrogen receptor negative or positive breast cancer? And again, as I said before, there's not much to go on because there's not very many studies that have been done and the numbers are really small. But from that, they concluded that the overall answer to can I take HRT after breast cancer was no. But if you split it up between the estrogen receptor positive and negative, it seemed to be safer in the estrogen receptor negative cancers, which is what you'd expect, if it's got estrogen in it. But that doesn't mean that your oncologist is going to be happy about it. I think that's the issue really. But it's worth, if I can direct you to that study, you could take it and show it to them and say, what do you reckon?
You see, that's where I'm conflicting now. Do I just go with what my oncologist said, or do I go privately to a menopause specialist and see what they suggest?
Yeah, no, that's right. And as I said before, that's why we set up a multidisciplinary service, so that you didn't get, people talk to each other. After breast cancer, nobody in their right mind is going to prescribe HRT to somebody without talking to the oncologist. So your oncologist has to be on board. So you could show them that new information and see what they think. And it might also, like I said before, it might depend on whether or not you've still got breasts, or whether or not you've had a bilateral mastectomy. Those sorts of things would come into it.
We've just had some requests from online. Some individuals didn't hear your answer on the role of diet and exercise in menopause, and I suppose if you just want to maybe comment on it just for the people online again.
Yes, so I was just supporting healthy diet and exercise in all circumstances, and including after cancer. But diet and exercise has not been shown to treat any of the symptoms that I've talked about today. So it has benefits, but it doesn't seem to have specific benefits, for example, for hot flushes.
Thanks, Martha. So just a few more questions online. So can Vagifem for vaginal dryness be taken long term? Yeah,
so probably is the answer to that. Again, the most recent evidence shows that it's safe for a year, although a lot of women use it for longer than a year, and it's probably okay. You talked about the Women's Health Initiative study earlier on. They looked 18 years later at women who used vaginal estrogen, and they were okay. So probably.
And what about if you have metastatic breast cancer, about using estrogen creams?
Yeah. It's a difficult area, and there's no data. Again, I think it really needs a listening oncologist in those circumstances to think about, it hasn't been shown to be unsafe in any women with vaginal estrogen, but the oncologist may be keen for them to avoid absolutely all estrogen in all circumstances. So, sometimes they need to understand how much these symptoms are impacting on the woman and her quality of life.
We've got a few questions about hot flushes. So still having terrible hot flushes 15 years after breast cancer, will they ever go away?
Yeah, that's really difficult. I guess I would encourage her to consider some of the non-hormonal options for hot flushes, which, as I said, there are several that work and are safe after breast cancer.
Any questions in the audience? Person? Yep.
So with estrogen positive breast cancer at 45 and going on Zoladex and aromatase inhibitor, when you come off those, say after the 5 years or so, and you've dealt with all the menopausal symptoms at the beginning, are there chances that your period's going to come back again? And that
it depends, because presumably you've had chemotherapy as well.
No.
Or no chemo.
Yeah.
So in that case, it depends really on your age when you stop.
Okay. So I think it was, I roughly remember that it was 5 to 7 years. So it'd be 50 to 52.
So at 50 to 52, most women will be postmenopausal.
Okay.
So the unfortunately, even if you've got ovarian suppression, it doesn't prevent a loss of ovarian follicles.
Okay, so if you had more follicles still to go, you would get your periods back?
You might do, because some women go through menopause later at 55, 56 or whatever. But there wouldn't be a way of predicting it, unfortunately.
Okay, thanks.
You wouldn't know. There's not a way of knowing.
Any other questions in the audience? Yep.
First of all, thank you very much for your presentation and for all the information you're giving. I'm just looking for some advice. I'm post-hysterectomy for ovarian cancer and would certainly have issues with sex drive and complete lack of it. Would you have any pointers? Thank you.
It's such a traumatic thing to have experienced. and certainly it's a thing that women lose or may lose sex drive after they've had their ovaries out. And people speculate that it could be because of the loss of testosterone, because your ovaries would have been producing testosterone even after menopause. So in those cases, in that circumstance, if other things don't work, then it's probably worth having a discussion about testosterone. But there'd be a lot of uncertainty around safety of that.
Just back
And
to
not if you're taking a aromatase inhibitor.
back to some of our online questions. So some people are wondering, why are some patients not put on Zoladex?
So I'm not an oncologist, but I think that Zoladex is suggested to premenopausal women who have estrogen receptor positive cancer in association with a aromatase inhibitor. And the reason it's suggested is because a big randomized controlled trial showed that the cancer outcomes were better after that compared to what was the previous standard of care, which I think was tamoxifen.
Can I take supplements which contain soy products while I have cancer?
That was kind of a similar question.
Yeah.
Well, I would say food-based. Yeah. Supplements probably got more, it's different sort of estrogen type things in them. I don't know. I don't think anybody knows the answer to whether or not that's safe, or they haven't been shown to be effective, but I don't think anybody knows whether or not it's safe.
Great. So we have a question here online about options financially if you're unable to go back to work, and you have cancer. Obviously, Martha wouldn't have the expertise there in terms of the Irish system. So if you ring our nurse line on 1-800-200-700 in the Irish Cancer Society, we'll be able to advise you on that question. Can the Mirena coil be used for heavy bleeding in perimenopausal women 5 years post ER/PR positive breast cancer?
Probably. I mean, again, that's a question for the oncologist. So Mirena is a really good treatment for heavy bleeding, but it does contain some progestin, which is a hormone that, ER/PR, the PR is progestin receptor positive. It does contain that, and some of that goes into your circulation, only a tiny amount, but it is equivalent to taking, I think, something like 1 mini pill a year or something like that. It's very small. But that question probably need a discussion with the oncologist about whether they were comfortable with that tiny amount. Would depend on the cancer. Yeah.
Okay. Do we have any more questions from the in-person audience? Yeah.
Sorry, I'm just asking this question because this subject has come up a lot about the HRT, and I'm just wondering, are you aware, I have heard that there is development of some medication for people who have women who have had cancer that can be taken instead of HRT. Have you heard about this or any comment on it?
So there's a couple of things. So there are existing non-hormonal treatments for hot flushes and night sweats that are better than placebo. And to put it into context, HRT will reduce your hot flushes by about 80%, and these non-hormonals will reduce them by about 40 to 60%. So it's not as good, but it's not bad. So there's a new medication that I think there'll be a research project starting on here soon, which are a completely different type of compound called neurokinin B receptor antagonists. And they target the bit of your brain that causes the hot flushes. They haven't previously been used in cancer, as far as I know. I think this might be the first study in cancer. But in non-cancer, they seem to be really effective. I mean, I've seen figures of hot flushes going in a day. So they might even be more effective than estrogen, but they're not out there yet. And when they do get out there, they'll be very expensive. I think that's probably the thing we'll notice more than anything else. But they might be really effective. But it's very important that this research gets done in cancer as well. Not only for safety, it'll be hard to have a safety endpoint, but that they work. Yeah. It might be a complete game changer.
Thank you. There's a couple of questions here about vaginal estrogen and whether it's safe to use this as a local remedy for vaginal dryness if you've had breast cancer.
Yeah, again, a really good question, and we don't have any international consensus answer to that. The Americans have an answer, which I think is a good one, which is that if you've had breast cancer, you don't go straight to vaginal estrogen, you try other things, and I've talked about what the other things could be. And if they don't work and it's still a problem, then, you know, in discussion with the oncologist, you go with vaginal estrogen. I think that's a very reasonable approach.
Thanks, Martha. Can HRT be used for ovarian cancer? If you've had ovarian
After
cancer?
ovarian cancer, usually. Yeah. But again, it's, you know, the ovarian cancers vary, and if it was an ovarian cancer, for example, that was strongly estrogen sensitive, then it wouldn't be, or estrogen sensitive at all, it would be a bad idea.
Any more questions in the in-person audience? Yeah, of course, yeah, we'll give a copy of we'll have the recording of the presentation today as well. Okay, if there's no more questions, I might leave it there. And I just want to finish up by thanking Martha for a brilliant talk. Crowdcoms for hosting our very first hybrid event. Hopefully it all went seamlessly behind the scenes. And Rebecca, Ivory and my team who slaved away for the last 3 weeks to make today happen, and we're very appreciative. And thank you all for attending the event both in person and online. And just a reminder, I know there was a lot of very specific medical questions today that really need to be answered by your own medical team. As I said, they know your medical history, so please, if you do have any questions, please ask your own doctor. And if you have any questions, you can always ring our nurse line on 1-800 200 700 and they'll be happy to give you some advice. Thanks a million. Bye.
Thank you.